Sure. So I'm Jennifer Craig. I am an associate professor at the University of Auckland in the Department of Ophthalmology. I am an optometrist by training, so I began my career as an optometrist doing my training at Glasgow in Scotland, and I did a pre-registration year in the hospital and went back to do a PhD under the supervision of Alan Tomlinson, again at Glasgow. So yeah, so I have a PhD. I've also got a number of fellowships that I've done since then. I've got with the American Academy of Optometry and the British Contact Lens Association. I've got an MSc in cataract and refractive surgery, and I've also been awarded fellowships by the Cornea and Contact Lens Society of Australia, and I got the Life Fellowship of the College of Optometrists, which was amazing last year. And most recently, I was awarded fellowship, the Dry Eye Fellowship for the British Contact Lens Association. Most of them have been related to my work in dry eye. So that's the kind of area that I started in with my PhD. My PhD was in tear film in the normal and the dry eye. And I guess I've kind of stuck with that. I've branched out into other areas, which is where the refractive surgery, cataract and refractive surgery areas came about. I've worked with ophthalmologists and done research in that area, but mostly it's been about dry eye and ocular surface disease that I've focused on. Mhm. Yeah, I think there are two things going on. I think one is that we're getting better at looking for it and looking at it. I think we're realizing the impact, both the how common it is, because it's incredibly common. I mean, it's in somewhere up to 50% of our patients. So if we say a third of our patients approximately who walk into optometric practice have some problems with dry eye or symptomatic of dry eye, then we realize it's a far-reaching problem. We realize more than ever now the impact that that has on quality of life. Um, and so I think we're looking better for it. We're trying harder to look for it. We've got better diagnostics for diagnosing a dry eye than we've ever had before, and trying to work out what type of dry eye somebody has to understand the source of the problem. But I think the other thing that's going on is that it is actually increasing in prevalence as well. Age is a big factor. People are living longer, which is fantastic. Um, but with that, we get more people experiencing dry eye. I think our expectations are increasing in life. As we get older, we don't expect our quality of life to be affected. We want to still maintain things that we were always doing. We expect to still be able to use the computers. We expect to do things into older age. So I think patients are becoming a bit more demanding and are, which is good, and actually approaching optometrists and eye care professionals looking for help when they need it. I think the other thing is the environment that we're exposed to, both in terms of the air quality and things like that. We know pollution can affect dry eye and increase its prevalence, but also the lifestyle that we lead. So the use of computers, the use of digital devices. We know when we use those, we concentrate better, we stop blinking so well, or blink quality changes in terms of the amount of the number of blinks, but also in the quality of the blinks, because we're concentrating too hard. And I think in doing that, we're seeing an increased prevalence, either directly or possibly even pathophysiologically, in developing a dry eye from things like that. And you combine all of that with this kind of sedentary lifestyle that we unfortunately have now, where we're in air-conditioned environments, where we're in environments where we're really not doing the best for our eyes, and airplane travel and things like that, where we have very dry environments, will also contribute to the problems that people have. And those impacts, I guess, are helping lead people into the vicious circle of dry eye disease. If we have instability of the tear film, we see that reflected in increased osmolarity of the tears that induces hyperosmolarity. So increased evaporation of the tears, sorry, that induces a hyperosmolarity. The tears become more concentrated. That affects the cells in on the cornea and the ocular surface, and they then don't survive as well. And as we lose those, we have an inability to support a tear film, and that causes more instability, which again leads into that cycle of instability, hyperevaporation, hyperosmolarity, and damage and inflammation. So yes, that's what we need to try and avoid. But unfortunately, our lifestyle is not really allowing for that so much now. I mean, I think being a clinician as well as a scientist, I would hope that my research does appeal to the optometrist in practice, because a lot of the questions I have come from a clinical basis. You know, they're the questions I have in practice and the questions others ask me on the basis of their practice. Like, does this device work? What should I be doing? How do I identify the patients that will benefit from, various things? And so, in trying to answer those questions, I guess that's where my research comes in. And so, yeah, I would hope that it is really relevant. I mean, it's even if you go back to some of the work we do is things like epidemiological, but that's understanding who gets dry eye and why, understanding the natural history of dry eye, how it develops, understanding what the risk factors are for dry eye. We need that as clinicians to be able to say to a patient, well, you're doing this or you're doing that. That gives you an increased risk of 1.2 times in developing whatever. And so that information is important, and we do research in that area. We also look at the way that it develops, the way that dry eye develops. Some of my work on blinking and trying to understand if that actually is one of the drivers of dry eye development. And that's important as well, because it may be something that we can intervene with as clinicians, and encouraging patients to do more blinking exercises and things like that to try and reduce these effects if it turns out that that is actually a driver. And then the other work that I do is more easily translatable into clinical practice, and that's to do with the diagnostics and the therapeutics. So I've said that there are more there's more diagnostic instrumentation out there now, and that's great. And people are taking that on board and increasing the types of instrumentation they have in practice. But in using them, we need to make sure that they're all equivalent, that we know what the appropriate cutoffs are for the different instrumentation. And we put that together into a kind of diagnostic algorithm, which you may have seen from the TFOS GS2 report. They came up with one, and that's what we can use to help us decide whether or not a patient has dry eye, and how we're going to try and manage it based on subclassifying the disease. So yeah, so we do some work in that in trying to optimally diagnose dry eye. And then finally, we look at the therapeutics, and that's answering direct questions of, does this product work? And we do that through randomized controlled trials as much as possible. So somewhat like you do in practice, only we make it very, very strict. The patients become participants. They're signing up for something a little bit different from standard care. We can't just give them every treatment we might think of doing at any one time. We narrow it down so that we're only changing one thing at a time, because that way we're able to see whether that one thing is making a difference. We put patients or participants into trials that are masked so that they are randomized to receive treatment or not. We try and emulate the treatment as much as possible as perhaps as a sham or as some kind of placebo treatment, so that the patients or the participants believe they may be having the treatment, and will give us honest responses, and we find out whether or not the treatment made a true difference. And we do the same for the clinicians. The clinicians who are collecting data don't know which group the participant has been randomized to. So I think across the board there are very many parts that are highly relevant. Yeah, so I mean, the Dunedin study is a multidisciplinary trial which has been ongoing since 1972, when they recruited about 1,000 babies who were born that year into having lifelong follow-up. And so and many people have seen some of the outcomes of that. It's been on the TV. And so what we're doing this time is we've had the opportunity to get looking at their eyes and looking at their ocular surface and their dry eye, then to look back at maybe some of the history, some of the background as to maybe why they have developed dry eye in future. Yeah, I've been really lucky. I've been on sabbatical and developed collaborative links, and we've been lucky to get funding to do an international multi-center trial. So I'm working with there are four groups, our group in New Zealand, as well as in Australia, Canada, and the UK. So yes, that's really exciting because it's all very controlled. I mean, the one step beyond doing a randomized controlled trial is to make it multi-center so that you spread the load across different sites and theoretically even less risk of bias.